Well, and I'll just give another example. I got security, so security was under me, and I wanted to know what do my officers do. So I took Taser training, and I did it prepped ahead of time. I was ready. They do the scenario. I'm looking like a badass. I got my cargo pants on and my hipster Taser, and the guy came at me with a plastic knife, and I knew very well it was a plastic knife. But instead of doing what I was trained to do, I ran into hightailed it out of there. I was like, oh my God, this is what they have to deal with literally every single day.
Hello and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I am your host, Lee Scheinbart, and this podcast brings you stories and wisdom from some of the best leaders in healthcare today with a focus on the role of the CMO and physician leadership. Today, it is my pleasure to introduce Dr. Ghazala Sharif, Corporate Executive Vice President and Chief Medical and Chief Operations Officer at Scripps Health in sunny San Diego, California. Dr. Sharif grew up in Ann Arbor, Michigan, and earned her undergraduate degree right there at the University of Michigan, and later earned her medical degree at Michigan State University before entering an emergency medicine residency at Stanford, and ultimately completing a pediatric emergency medicine fellowship at Rady Children's Hospital in San Diego. In 2011, Dr. Sharif earned one more degree at the University of Tennessee in their PEMBA program, otherwise known as the Physician Executive MBA program. And most recently, Dr. Sharif was featured in Becker's Hospital Review in a piece entitled The Benefits of a CMO COO Role. Dr. Sharif, welcome to the show.
Well, I'm honored. I think you're going to be my new PR agent, Lee.
I'm open to
I'm
that.
impressed with my own self.
I don't charge much. I'm happy to do that. Listen, I'm really excited to have you on the show. We have a wide mix of curious listeners, many of whom are exploring physician leadership roles. But we never interviewed anyone who has your specific title of CMO, COO, and I'm sure our listeners are very curious about that. But before we explore it, let's talk about one thing you and I have in common. We were both undergraduates at the University of Michigan, and you were simply one class ahead of me. So I've been dying to ask you this very particular question. Did you ever visit Stucci's Ice Cream on State Street?
I absolutely visited there. It was one of my favorite places to go. You could do the mix-ins. You remember that? You get the mix-ins and you
Oh, I remember it.
It was like a treat when we used to go there, right on the corner. I know exactly where that was. So,
and in addition to the mix-in, did you ever get it in a waffle cone?
Didn't get the waffle cone. It was too big. It was kind of messy. But yeah.
So,
memories.
I ran out of money in my junior year, and I was super lucky to land a job there. They had literally just opened like in 86 or 87. So I'm working there in 88, and I got the job of making the waffle cones as well as the mix-in, which you had to really work really hard on the stone cold marble to get everything mixed in, right? You remember that?
I used to work at Baskin Robbins when I was in high school. So I got my one muscle, scooping muscle.
So we got two things in common.
There you go.
Unbelievable. And I used to smell like waffle cones at the end of the day.
That's a great smell.
Well, yeah, until, it smells the entire apartment. Everybody wants to kick you out. So you got to wash your clothes more frequently. Well, anyway, it is crazy that after 40 years, you and I are both in physician leadership roles. And I served as a chief medical officer, and now I do physician leadership, education, and teaching. And I'm so thrilled to be able to have you on the show. And the twist is you've got multiple titles: Executive Vice President, CMO, COO. So explain this dual title and how did that evolve and how did you prepare for that?
So it's such a great question. I love this role. I think what I would recommend is more people look at it because we're able to go much faster in the sense of, I know operations, right? I have the 5 hospitals at Scripps reporting up to me. So I know what's happening, boots on the ground. And if I need to expedite something, it's direct to me. We don't have to go through this person, then that person, and that person. It's really rapid change. And being an ER doc, I'm all about rapid change and pivoting. Try fast, fail fast. If it doesn't work, let's pivot and do something else. And that's the value of the role. A couple of years back, we started a new capital planning process, which involves physicians. Before, as you probably know, Lee, it's a administration said, here's your budget, here's what you get. And we had no really physician involvement, even though we have service lines. So we started this new process now where the physicians are involved up front, trying to help us prioritize capital spend. And so they know exactly why we're doing what we're doing, and there are voices out there. And that came from my role, right? So if we didn't have that, it would have to go through many different iterations before we got to the physicians. So how I got there was your second question. We can delve in. I became chief medical officer 2 months before COVID hit. Lucky me. And so jumped into the incident command center director with my CEO, Chris Van Gorder. And so that led to a different role, interestingly, which not the supply chain, support services actually went to Chris and asked to report to me when there was a leadership change, unknown to me, by the way. I had no idea they were asking Chris for that. That was unusual in and of itself because Chris had no intention of giving chief medical officer food, nutrition, engineering. What do I know about engineering? Not much at all. But the fact that they asked for it, he gave it consideration. And so he gave me all of those services, which was great. I went rounding with the engineers. They taught me. And so that started the journey. And then what really, and I was in touch with our regional chief execs anyway, I was doing patient experience. Our regional chief executive, Carl Eder for the North, was in a very serious accident, cardiac, and had a bike accident at the same time, and was in the ICU when we were there when he was transported. And Chris said right at that moment, he goes, I want you to take over for Carl. And frankly, he did not want his job. I think that's why Chris put me in there. Sometimes you fill the gap and not because and he asked me if I wanted, he actually said, Chris, I'm going to pay you more for doing this job. And that just did not sit well with me, Lee. Here's my friend literally, vying for his life. And I just could not take the money. In retrospect, I did it out of the goodness of my heart, but it did set a precedent, with the board as well, because Chris told him she doesn't want money. I'm just keeping his seat warm until he comes back. And he came back in 3 months. I rearranged a few things while he was gone. And so since it worked so well, Chris said, why don't you take over the South leadership role as well? So I did that. And then I had 5 hospitals. And so it just kind of made sense to change the title because that's what I was doing. I was running all of our operations meetings anyway. Same thing happened on the ambulatory side, right? Our chief medical officer for ambulatory was doing operations. And so it just made sense. We don't have a chief operating officer separately for the system. And that's how it evolved. Literally, I had no intention of doing this job this way because I was happy being a CMO alone, but it is so much better this way.
Well, I want to unpack that because I find that rather unusual and astonishing in a couple of ways. So, healthcare and hospitals and large clinics have a ton of inertia. They don't change. They don't want to change. And the idea of a fail fast move, emergency medicine notwithstanding, is a traditional startup mentality. And I've been involved in some of those. And Southern California certainly has a lot of that startup mentality. But that is a very unusual place for hospital leaders to want to be for fear of mistakes or going in the wrong direction. But physicians are so well trained, not that we should fail, but that we are ready to jump in to triage the situation, make the best decision. And you know what? Oh, we need to change that decision immediately. And so that puts a physician leader in a great spot if you're in an organization that is willing to do that kind of thinking. So that was one thing I found really interesting. The other thing is most of us were never really in a command center until COVID. Now, I have been a part of, and perhaps you have as well, for hurricanes and other things, and you all have wildfires and lots of other disasters. So to the extent that being a physician, an emergency physician, being in a command center, and then all of the supplies and engineering and all of the things that need to happen to provide massive clinical care quickly actually, again, puts you in the right spot, money or motivation notwithstanding. You are adequately trained. And I guess all of this commentary is if you could redesign the role, and knowing what you know now, would you still want to have both of these components so that you and your physicians understand the money from the bottom, the problems from the bottom, and move? Do you still like that?
Oh, 100%. When I took over the position in January of 2020, January 13th, one of the first things the board members asked me to do was fix our leapfrog scores. We had 3 C's, a B, and an A, which is not reflective of what we do. We just were not focusing on the right areas. And so we started what I call sprint teams. And sprint to me means you move fast. You can have stickies on the wall, but you do not sit there and go round and round in a circle. Perfection and complacency, I told the team, is our enemy. Right? Let's try it. Let's look at the data. Let's look at the cases that are contributing to our numbers, hospital-acquired conditions, readmissions that were contributing to our low scores. And we formed literally 7 sprint teams that first year, which may seem like a lot, and it was, but we had the right leadership in place with a physician executive on every single one of those sprint teams to help drive change. So those are called sprint teams. And then once they're done with their acute work, we if it needs to go, like catheter-associated urinary tract infections, they're never going away. You're going to have some of those, and we have a task force if the sprint wasn't enough. And that really changed the culture of our place. So in the midst of COVID, we're trying to get our quality numbers up as well with these sprint teams.
That is brilliant. I've talked to a lot of hospital executives, and I've seen a lot of different tactics, but a sprint team led by a physician and time limited. Okay, we nailed that one. Let's move to the new season. Like we're starting over, like, boom, let's do
There
this.
you go.
I think that's great. How many beds do you oversee?
Gosh, we have, well, each hospital has at least a couple hundred. So 5 hospitals times at least 200. Some have 400. So that's lots of beds. Haven't done the math yet, but
Over 1,000
oh
beds
yeah.
easily. And you said roughly 9 sprint teams
My
approximately?
first year was 7. Now
7?
we're down to 2 because we've been doing this for 5 years now. So,
Right.
but we have task forces that keep looking at it. So yeah, we had a physician operating executive and a chief operating executive at those first 7. Now we're down to the manager level, which is really cool. That means we're spreading into the organization because it's working so well, but we always have at least one physician on those teams. Usually multiple.
That's great, because another person who's listening who has several hospitals, I had about 900 beds, and I'm thinking in my head, okay, how many sprint teams? And I do a ratio, maybe 1 team per 100 beds, or now that you've matured, you can look at different things you're trying to affect, and you have a better sense of how many people you need and at what level. And the empowering and the agency that you provide to your physicians to activate them will absolutely change the culture. And that literature is out there. And I applaud you guys for doing that. Do you think that chief medical officers, whether they're in an ambulatory clinic or within a hospital, should lean in more? I mean, this may be an obvious question, but getting into operations or asking for more operations and less medical staff, less credentialing, and getting into that other stuff. Do you think they should?
Oh, I absolutely. I'm sorry. The question, I was like, yes.
Yeah, no, I
Yes,
left
they
you
should.
hanging there. It's all right.
And quality always is under the chief medical officer role. Patient experience, that's sort of a given, but it's a how you do it, right? And how
Yes.
you engage. And one lesson I've learned is a vision is just a vision unless nobody else follows you, right? And so if I'm bossing people around, it's not going to work. You've got to have those frontline folks solving the problem for you. Now, what I do give them is we have a checklist. I'm very checklist oriented. So you have to develop a checklist for your sprint team. So it's really clear. Step 1, 2, 3, 4. So if there's an outline case, like I said, you're going to get some catheter associated UTI, just going to get, but did you do everything that was standard of care?
Right.
If you did and you got one, so be it. But if you didn't, let's go back and retrain our staff, right? And so I think, that part's already there. The operations piece, I think it's so important. Again, you can go much faster. We help the physicians talking to other physicians help. We have our CFO who's fantastic with doctors. He's out there teaching them because frankly, we didn't learn enough about business, right? We're always trying to be at the bedside, and it is turning, and you're smiling because it is turning to business. You have to understand. And I'm not suggesting everybody go get their MBA, but I do think that understanding the why is so important. And then we can explain why you can't have your cath lab in the north because we need to get the Da Vinci robot in the south because that's what's lacking. And that's the fun part of what we do now. I call it a little horse trading, okay, you get this, you get that, but here's how it looks as a system, right?
Right.
We've got to work as a system. And so unless you have a physician there knowing what the clinical needs are, I think it's really difficult.
No, I agree with you. And it is clear that when you and I, so back in Ann Arbor, right, I spent some time at the hospital doing some research, and when I was allowed to go on rounds as an observing student, not yet in medical school. Yeah, the financialization of medicine was not obvious and was not in our face. It was happening,
Right.
but it wasn't right in front of us. And the level of decision making
Right.
around the financial restraints and constraints and so on and so forth. So yes, at some level, the House of Medicine is failing early and mid-career doctors about how to navigate an increasingly complicated financial arena that affects the decisions in ways that we didn't think about 40 years ago at all. So I agree with you. What's the hardest thing that you have faced in this role, aside from COVID and your dear friend being so critically ill? What's the hardest thing you faced?
That's such a great question. I think when I first started the role, I'll just be honest. When I first started, even though there were two of us, my Dr. Kiswani is ambulatory and I'm this one, there was definitely that, why is she getting the role, that kind of thing. And so I think in a way, COVID, because but take a step back, we initially had one chief medical officer over everything, and it was not working. It was too big. And things weren't getting done, like the quality was suffering and all this stuff wasn't happening, right? And so that's why Chris, our CEO, decided to split the role. But there was definitely that, why did she get it kind of thing. I do think when COVID actually did me a favor, believe it or not, because got a chance to show leadership skills, right? Because
Right.
initially I had to be very directive. I mean, there was so much misinformation coming, CDPH and county. It was just all wrong, frankly. We went with the Doctors Without Borders recommendations for PPE. And I'm glad we did, because we went a step above what everybody else was saying. And so there was so much panic and confusion. I think the hardest part was seeing and hearing that level, especially in the physicians. We don't panic. And when I'm getting those phone calls literally night and day from staff, that was tough. And when we lost our first employee to COVID. But I think it was that jump start and trying to have to prove myself. I had many, many conversations with some of the physician leaders. Are you going to be supportive of me in this role? What do I need to do to gain your trust? But then COVID hit, like I said, and they had to come on board. And then we had a cyber attack. That was the next thing, Lee, that kind of, I ran that incident command center with my CEO, and it was the first time that the physicians actually asked me to come out and round with them, which is fascinating. Not once during COVID did they say come out, and I would show up, when they needed me, because we didn't want to distract them. But during the cyber attack, they said, "Can you come around? We need your help." And that was tough. So I never want to go through that again. 3 weeks of being under cyber attack was still, we get PTSD every time there's a code white announced, because that was so hard. By the grace of God, we did not, injure any patients, but I could see how that could happen. So I gave you a lot of difficult times in there. So I can't quite answer your one
Yeah,
question,
no.
but that's it. By the way, I was probably a phlebotomist while you were doing your rounds at University of Michigan, because that was one of my jobs. So we got a double or triple thing here going.
Yeah, no. Now I have PTSD about your PTSD and my PTSD. It's all coming back to me, all of the things. But no, you're right, and I think that is again perhaps an unfair occurrence in our medical training, that we don't trust administrators. We are actually
That's it.
taught. I'm going to put it out there. We
Yep.
are taught as young physicians, competent beginners, to not trust the administrators, the
Exactly
people in the
right.
suits. And that's not right, especially when a physician, and to your point, should she really have the job? Is she qualified for this job? And it comes from both sides. It comes from the administrative side,
Right.
comes from the
Right.
physician. And it's not fair. And then clearly, just like you earn your degrees, you earned their respect, and they wanted you to round with them during a cyber attack incident,
Thank you.
when it is really a very uncomfortable place for people who've never been on an analog paper chart or how to find things,
Yeah.
call the lab themselves.
Yes.
You and I would
That's it.
probably run down the hallway to look at results when we were impatient. We would go
Yes.
get our own results,
Yes.
right?
Yes.
That's those, but a lot of young physicians don't understand how that universe existed, and it's a frightening moment when
Yeah.
all of those things are taken from you. So, yeah, those are hard things, but I still say, and I put this out there frequently, that's why physicians should be leading healthcare because we're the only ones actually trained in healthcare, which
Yeah.
involves a lot of moving complex parts all of the time.
Can I just
So,
interject? When you said something that, thank you for that, by the way, the trust. I didn't think of it that way. So you just kind of, that's what it, well, I didn't know. I'm like, why the heck are they asking me to round it? But it was helpful because at one site we had a whole list of what's new today. Because imagine this, you're in the middle of a cyber attack. You don't have time to read your emails and
right.
things were changing so quickly. Here's a PAX unit that's available. And so one of the sites had what's new today. It was brilliant. Such a simple thing. So all the staff go by this wall, see what's new today.
Yes.
And so we were able to take that and spread it when I was rounding, like you should do the XYZ. But you said something that's really important, and that's a distrust that we have as physicians of administration. And I'll tell you, even to this day, my CEO every other day tells me I'm an administrator, and my answer is, no, I'm not. I'm an ER doc, first, second, third. So even to this day, even though I'm quote an administrator, I refuse to believe it.
Well, I may have to be your PR individual as well as your executive coach and help you reform your identity. Look, no one will ever change the fact that you are an emergency doctor. That is your identity. That is who you have become. And if you're in a room with 100 people of mixed administrators, nurses, whatever, and somebody says, so what is your name and what do you do? You say, I'm Lee and I'm an oncologist. Like it comes out of your mouth before you even
That's
I'm
true.
not a father. I'm not a husband. I'm an oncologist, right? So
It's
that
funny.
is a very true observation that is who we are. But we can be an emergency medicine physician and an
Yeah,
administrator,
that's true.
right?
That's
We
true.
we don't
Yeah,
have to unidentify and re-identify. I think we
right.
can be all of it. So yeah, we could go on a long time about this. Let's pivot to something even harder
Okay.
because I ask this of a lot of our physician leaders, and I do find that our younger listeners do appreciate understanding this. Part of it is because many of us don't have a good mental model if we didn't come from a family of physicians of what it's like to be a doctor.
Yeah.
And I think our young leaders don't exactly know what it's like to be a chief medical officer. So, what is the hardest thing for you personally in the role, for you as a human being in this role?
For me, it was especially during there's 2 times in my life when my kids have come to me and said, "Mom, you are not present," because I'll be at the dinner table in my head. So this work-life balance thing makes me nutty. I wish somebody had not said that to me. Honestly, I when I was with the kid, my I have 2 daughters. When I was with the kids, I was worried about work. When I was at work, I was worried about the kids, and it was making me absolutely I couldn't do it. And finally, the
I
one
didn't mean to laugh at you.
but
It's just I feel this it drives me nutty too, so I wanna hear more.
Yeah,
Keep
well,
talking.
finally, work-life integration, that is the new terminology, which I love. And so I had to realize that, well, if I'm at the dinner table and I'm not listening and they have to tell me the same thing 3 times, so we started doing like Magic Monday, Terrific Tuesday, Fun Friday, and it's the quantity of time versus well, quality. I said it back, quality of time, even if it was 20 minutes, where we'd go to the park, get Subway sandwiches, and sit there, versus being there for an hour and absolutely not being present. I remember being at Thanksgiving with friends, and we have this dumb thing when I would joke around about each other's mashed potatoes. It's just a thing we do. It's a stupid thing, but it's just fun. But I was going through the motions, and my friend pulled me aside and said, "Ghazala, you're here, but you're not here. So you might as well go home." And it was just a little. He was being kind in a different way. It was kind of slap it to reality. And so they still during COVID. That was when I was at Rady's, and during COVID they said the same thing. So they ground me in a way when I'm just too into it. It's really hard for me when I'm in. I'm in. We're very passionate people. I'm a Scorpio as well, on top of an ER doc. So that for me is a struggle, is not thinking about things at nighttime and trying to solve the problem all the time. Because as an ER doc, it was great. I'd go home, I'd run the cases in my head, like we all do. I'm sure there's cases, Lee, that you have that you think about, like, well, what can I do differently? But then
Mhm,
you can kind of shut it off, right, after a certain time. This
mhm.
never stops. This is 24/7. That is hard. I don't know if you know, but I had a spinal cord injury 2 years ago. Still recovering from that. Trying to manage that at work has been a blessing for me. Otherwise, it'd be rehab 24/7. So I think that's hard, is just staying grounded.
Well, thank you for sharing all of that. I have heard similar stories because I was an oncologist and didn't have shift work. I was never mentally present at the dinner table. I was always
Okay.
ruminating about the day
That's a
that
good
I
word.
had,
Yeah.
and I never really paid attention to work-life balance. I just thought work was life and life was work. It's all one thing,
Yeah.
and I didn't understand, perhaps to your point, how people created some level of separation. And during COVID and late and through my executive career, I became aware of my lack of presence, and
Yeah.
like you, found myself reorienting to what is, and maybe that was the mixed blessing of some of the trauma that we all experienced, all of us in this country and other countries, about how do we behave and take care of ourselves and each other during
Yeah.
things that we weren't born knowing COVID was going to happen, and it
Right.
happened and we had to deal with it, and other generations have had to deal with other things. So thank you again. And as well, with, I'm glad that you recovered from your spinal cord injury. After I left Michigan and went to Ohio State, I had the joy of being diagnosed with Crohn's disease and have
Oh
had that
gosh.
my whole life. And so the point of these questions are, we are real people, we are human beings, we have identifications, we have titles, and we have roles, and leadership is about stepping back as well as leaning in and looking at problems from up in the balcony level, high up, and knowing when to flex down and solve that immediate problem, or grab a team, a sprint team, to solve the problem. And same thing, I'm either solving this patient's case or I'm present at the dinner table. I cannot do both, nor should
Right.
I do both. So
Right.
I am right there with you. We are kindred spirits. Go blue and all.
Yeah, you went to Ohio State. I'm going to have to frown at you for that, but
Well, you went to Michigan State,
that's
so
true.
let's
All
be
right, fair enough.
careful.
But Ohio is worse.
Fair enough. I take the criticism.
The other thing I would tell people is not to have your phone at whatever meal you're having with your family. My husband put in this rule: no phone at the dinner table, and I think that was the smartest thing he did, because otherwise I'm attached to it all the time. And there's got to be that, like you said, for an hour. Like right now, my CFO was calling me. I'm like, oh God, I got to do this, and I got to call him back. Wait a minute, I'm doing a podcast with Lee. Let me enjoy this time. I will call him back.
Yeah,
Do
yeah.
you see what I
No,
mean? It's a sense of urgency I have around everything. So just, I would recommend, if you're going to do one change, it's not have your phone at dinner.
that'll be our first podcast rule. No phones at a meal. No phones at a meal,
No
period.
phones.
And that's it.
Don't do it.
All right, so let's think about the future a little bit.
Okay.
You're in California is a very, very active place for healthcare, especially the San Diego, La Jolla area, all of that. What do you think the future of hospital and acute care will look like? And let's stay in the inpatient and or emergency room environment. What kind of doctoring changes will occur to your people, to your physicians, your staff? What does that look like to you?
I think we're going to do a lot more hospital at home. Right now, California is a little bit behind on allowing a lot of that to happen, but we're ready to do that. I just think that is going to, as we think about all the procedures, Lee, that we used to keep people in for a week for them. Now they're doing same day hips, and it's like, whoa.
Yeah.
So there's going to be even ICU type things at home. So we've got to be able to pivot to that. We're standing up our central command center to kind of get ready for when we are allowed to pivot to that. So I think the doctoring is going to get a little different, and that's on the horizon. What I worry about is all these unfunded mandates that are coming down from the state. Medicaid cuts are looming. That's the other thing. And so you think about what's going to happen. They're all going to come. They're already coming to the emergency department. They're going to come even more. A couple of weeks ago, we have a small emergency department with 25 beds. We had 40 people waiting for inpatient beds and no place to take them out, and there are no skilled nursing facilities, enough. And so if you get influx of these patients, we're literally going to get overwhelmed in the emergency department. That is looming not so far away, unless we can get our hands around this and provide better care. Think about ambulances. I mean, in California, they do not get paid unless they come to the emergency department. So there's really no incentive. Why would you assess and treat, or whatever they want to call the terminology? Because there's no incentive. So we get people coming to the emergency department that really do not need to be there. But They come in by ambulance. And so in California, they're looking at you have to offload your ambulances 90% of the time within 30 minutes. Now think about that for a minute. You come in with a cold by ambulance, and now we got a chest pain, waiting in the lobby. I'm sorry, chest pain comes first. Then we're going to get potentially financially dinged. It just puts that as it's such a, adversarial relationship that is so unnecessary right now.
Yeah, one of our earlier guests framed it very well for my headspace, which is the biggest problem in healthcare from this person's perspective is access,
Yep.
because access is an affordability crisis.
There you go.
That if you don't have people equipped for getting care in the right place in the right way at the right time,
There you go.
it becomes an affordability explosion, and it just keeps
Yeah.
chasing itself. So if the most affordable way is to use the ambulance to get to the place, to get the access, then somebody's winning and somebody's losing.
Yeah.
But ultimately, the system is being crushed and losing. Not a problem you and I can solve, but it is something that an aspiring physician leader, an emergency medicine medical director, whoever is in charge of your other workflows and throughputs. These are things that
Yeah.
you cannot ignore.
Right.
These capacity issues, the overcrowding issues, the access issues. And I was just on with an attorney who is extremely worried about the Medicaid threat and what that will do to their institution. And I do not envy that worry. I hope to God that is not what happens, but
No.
I do understand that there are forces in nature that you and I cannot do much about right now.
Exactly.
Do you think that the hospitals will become the repositories of sicker and sicker people that cannot be hospital at home with a simple IV for cellulitis or something that doesn't require 7 days in house, and that therefore the care, the levels of care will keep rising within institutions, and the complexity of the procedures, notwithstanding we can do hips, 24 hours, but some of the other things, it's amazing, right?
Yeah. No, I think you're absolutely right that's my vision as if we get to pivot to the hospital at home, that would be good. But remember, we have a lot of behavioral health patients that we cannot place.
Mental health, behavioral health is a looming crisis that may be greater than the silver tsunami. People talk about the number of folks that are turning age 65 that are grabbing a hold of their Medicare or MA plan, and they quote the 10,000 a day, and then sure, fair enough, great, but they have coverage and they'll get their care one way or the other. But the behavioral health onslaught that is coming for reasons that are beyond the scope of this show, why so many people are in need of those services. But we absolutely have a shortage. And you know this as well as anybody on this show. You go down to the emergency department on any given day, it has become a substitute for behavioral health services. So you got your cold and you got your chest pain, and you got everybody in between who is dealing with a level of stress, crisis, anxiety, bipolarism, schizophrenia, all of it. And it is can be very overwhelming. And we don't have immediate solutions for that right now. So let's not talk anybody out of becoming a chief medical officer. Let's come
I was
back.
gonna say, no, it's fun. It's a fun job. It really
It's the
is.
best job. It is the best
Actually,
job in healthcare.
I'm telling you, it's a great job because if I came back, I'm literally still working. I can see my hands are coming around. I was paralyzed neck down, December 24th, 2023. So the fact that I came back to work last July, 6 months later, tells you how much I love my job.
What would you say if somebody wanted to be a chief medical officer in 5 to 10 years from now, and they're sort of mid-career, thinking about a change? How would you advise them to get ready for the greatest job in healthcare? How would you mentor them or guide them to that future, knowing the future is rapidly evolving as we speak?
Well, first, I think you nailed it. You've got to have the clinical expertise. So I see people coming, they're 2 years out of their residency and they want to jump in and get a leadership role. If you are not developed clinically and you don't have that reputation, as you said, you've got the trust. I mean, I was lucky I had 20 years of ER/PZR experience. So people knew my name in a way that, okay, I'm not just, freshly trained.
Right.
So I think your 5-year mark is really good. Not that you can't get involved before that. And that's an easy way. What I do see is everybody wants money for something. And I gave you a great example of when I said, I don't want, for a different reason, I don't want the money. You just step in. So volunteer, be on committees, lead committees, get that experience and that leadership under your belt without asking for money. Sometimes we'll pay you, sometimes we won't. One of our guys now is leading our emergency department service line because he volunteered to be on what we call RISE, Resilience in Stressful Events, which is physician to physician. If you're having a tough day, Lee, you can call one of your physician peers who's been trained to decompress before you go home.
Yeah.
I mean, how many times do we need that, physician to physician? We do a lot of
every ride home.
Every right, but we don't want to go home. COVID, my girl's like, I don't want to hear any more about COVID. Well, who do I talk to? I need to have somebody that's confidential that you can talk to. So he volunteered on that. His name came up. Now he's leading all kinds of things because he stepped up and he cared. That's the best way. My path has been, I call it higgledy-piggledy. There's no way I would have predicted 5 years ago that I'd be in this role. Do the job you're in and do it really well. Don't always keep looking for the next thing, frankly, I volunteered, actually was chosen to do things that people didn't even want to do. My first assignment, as I did a pre-fellowship with Chris, my CEO, for 2 days a week, I'd come in after my MBA on my own time, and they gave me ICD-10. What a crappy job that was. But we made a little card for the doctors. Just do this. Acuity, severity, etiology. Just dictate this. Don't worry about ICD. We had ICD-10 without a problem. And everybody predicted it was going to be a mess.
Right,
it wasn't.
right.
So
Y2K, ICD-10.
Oh, everybody was like up in arms, right? It was so easy. No, because I gave them this little ER doc card that we made. And so sometimes you got to volunteer for, not even, sometimes you're told to do stuff that's honestly horrible to do, but prove yourself. And I get OPPE. Who wants to do ongoing professional practice evaluation standardization? That was one of my early jobs. I did it across the system. Now it's unified, right? So sometimes you got to do jobs that nobody else wants to do and do it well.
No, I love this. I love this because I've not yet heard anybody talk about volunteerism. And, I made the comment earlier that if you don't come from a physician family, a medical family, a lot of your experience is unknown, and you do get focused on your clinical skills and the path you want to take. And you become unaware of all these other things. I love the idea that you shadowed. I would advise everybody to take some time and shadow a non-clinical administrator or a clinical administrator if you're lucky enough to have one, because there aren't a lot of us, and see what that world is like. And then if you are go all in at that point, period. That's it.
Yeah. Well, and I'll just give another example. I got security, so security was under me, and I wanted to know what do my officers do. So I took Taser training, and I did it prepped ahead of time. I was ready. They do the scenario. I'm looking like a badass. I got my cargo pants on and my hipster Taser, and the guy came at me with a plastic knife, and I knew very well it was a plastic knife. But instead of doing what I was trained to do, I ran into hightailed it out of there. I was like, oh my God, this is what they have to deal with literally every single day. And so they gave me a pass, but I'm like, no, I'm redoing that scenario, competitive and all, until I get it right. But It gave me, by doing that and rounding with the engineer, I even did food nutrition. I went and literally cooked in the kitchen with them. It gave them a sense of what they do is important, rounded with environmental services. What do they do? It makes them feel that they're important, and they are. And if you don't round with them and learn what they're doing, they're not going to feel that from you.
Oh, that is a beautiful sentiment. And yes, traditionally, security rolls to operations. I hadn't really been thinking through that. So you might have failed with the plastic knife attacker, but you absolutely get an A+ for going down into dietary and environmental services and engineering. It's like dirty job, hidden boss wrapped into one.
That's it.
And get into it with them, and they will respect you for it, and you will earn credibility and trust, because for them to live that life all day, every day, and they don't know who's making decisions on their behalf is unfair to the value that they bring to the patient care. We have a great story here on the Space Coast, and then we're going to wrap this up. That there were a lot of congressmen that came down to the Space Coast many, many years ago to take a tour of NASA and Kennedy Space Center, and they encountered a janitor cleaning one of the bathrooms. And somebody had the gumption to say, sir, what exactly do you do here? And it was obvious what he was doing, but he had the gumption to ask. And he says, sir, I help launch rockets. And the congressman said,
Love it.
excuse me? How do you do that? Well, there are a lot of rocket scientists here and engineers, and they're responsible for the mission, for the launch and the return of the astronauts. If any one of them should come into this bathroom and there's water on the floor and they slip and fall, how do I know that that won't ruin the launch and the mission and the return of the astronauts? So what do I do here? I launch rockets.
Love
So
it.
that's what our folks serving us breakfast do. That's what the folks cleaning
Great.
our rooms do. They take care of patients. They take care of
Yeah,
patients.
and because as we say, they're infection
Unsung
control,
heroes.
right? They are, and they were highlighted,
Unsung
lab,
heroes.
EBS,
Yeah.
patient experience, all of it.
This has been a fabulous show. Do you know why we call it the Fire Chief Podcast?
No, I was going to ask you about that because I'm like, this is physicians. Why is it a fire chief? That kind of fascinated me when you reached out, Lee.
Yeah, well, I look at it this way. Being a chief medical officer or a chief operations officer or a chief clinical operating officer, these are no small tasks and takes a lot of intentional preparation, although a lot of it does feel like a trial by fire. My old boss, he told me that becoming a chief medical officer is exactly like a career in firefighting. You go to a school, in one case firefighting school, in the other case medical school, and you train and you drill and you train and you drill until you're ready to go into that room, take care of somebody in extremis, or fight a fire. You're either putting on a white coat or you're putting on a uniform. You start out as a fireman. And one day somebody says, you'd be a pretty good squad leader, or maybe a captain, or maybe you could be the fire chief of the entire house. And my boss always told me, you're never going to be a great fire chief without first becoming a firefighter. To your point of why you have to have your clinical skills and get that down before you take on a larger role. So do you agree with that?
100%. I think we're like law enforcement as well, by the way. They have a lot of, stand by your people, right? And that's what we do. We stand by our people.
Well, it has been a pleasure to have you. I appreciate you taking the invitation to share your experiences. You have been listening to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. If you want to learn what it is like to be a CMO, if you want to be on the show, email me at leescheinbart@gmail.com or connect with me on LinkedIn. You can listen to the podcast on Apple, and you can also watch the videos of our shows on YouTube. Our show's website is thefirechief.podbean.com. I love talking with CMOs from all over the United States, so please connect, leave your reviews and your comments, and share this with your colleagues. And in the words of Sergeant Phil Esterhaus, let's be careful out there.